Good evening, everyone. Welcome back to You and Your Health. Thank you for joining our program this evening. If you're watching the program for the very first time, my name is Erika Roberts, a co-host of this program. And my other co-host is Dr. Edward Isuman. Dr. Eddie is working on getting our slides prepared for our next guest, so you will meet him momentarily. So just want to give you a brief update, an exciting update about Janelle. We had mentioned at our last program that any news that we get about Janelle, that we will provide an update here. So Janelle is going to have her surgery very, very soon. She's actually scheduled to fly out, she and her mother, to India tomorrow to begin the surgery process. So we want to thank all of those who donated towards Janelle's surgery. Thank you so much for your generosity and for your kindness and for all the prayers. And we certainly hope that the gift that you provided will be given back to you in tenfold. Because of your donation, as I mentioned, Janelle's surgery is happening. We received donations both here in the United States as well as Ghana. And so she will be again flying out, as I mentioned, tomorrow for her surgery. And we actually got to receive a copy of her visa as well as tickets from Dr. Yao. And then we had a conference call with Janelle's parents and the doctors as well this past Sunday. So as we indicated, and as Auntie Jane, steward for our church, indicated, any monies that are left over after Janelle's surgery has been paid for will be used towards purchasing equipment for Dr. Yao's facility, which is really the Kolibu facility, the child health department at the Kolibu Teaching Hospital in Accra, Ghana. So we're looking for an ultrasound machine, echocardiogram machine as well. As we all know, Dr. Yao is the only pediatric cardiologist. And so the goal is to train other people at different sites so that they are able to detect if there's an issue, because obviously early detection is the best way to help these babies. And so if you still plan to contribute, we certainly are willing to take the funds to help fund the cost of the devices that are needed by Dr. Yao and Dr. Ansong. So we want to thank them also for their efforts. They have been with us through this entire process, especially Dr. Yao, who was able to raise a lot of the money as well in Ghana to help with this cause and make all the arrangements for the family to be able to fly out tomorrow. So we're hoping we'll have additional news the next time we're back on the program about how Janelle's surgery went. And so just keep the family and all the doctors in your prayers as she proceeds with her procedure. So before we get started with this evening's program, we want to thank our last speaker, Mr. Jamal Hilton, a financial advisor that came on for his excellent presentation on how we can preserve our wealth. If you haven't watched that episode, I will highly recommend that you do so. A few people have actually reached out and are able, have already made changes to their money to make sure their money works for them in the future. A parent called and said that his son, who DJs over the weekend, wants to start an IRA with the income that he gets from DJing. So the teaching actually worked because people are thinking about how best to save for their future. As I mentioned, it was a two-part series. The first part was on March 30th, I believe. And then the first part had to do with how to build wealth. And then the second part that we just had last Tuesday, September 19th, was to how to preserve your wealth. So please take a look at that episode as well. So now we'll get started with this evening's program on ovarian cancer. Although this month is Breast Cancer Awareness Month, we have had a discussion on breast cancer as recently as January 19th this year with a breast surgeon who is also oncologist, Dr. Bridget Opong of Ohio State University Cancer Center on screening and prevention of breast cancer. That segment is still on the church's platform and available for you to review if you have not seen it. So we are focusing today on ovarian cancer, as is the second most common gynecologic cancer in the United States, and it causes more death than any other cancer of the female reproductive system. Studies have also shown a strong correlation between breast cancer and ovarian cancer, meaning that those who have a high risk of getting breast cancer may potentially also have a high risk of getting ovarian cancer. So we're extremely excited that we have Colonel Milla here to give us an additional information about this topic. So before she comes on, I'm going to give you a brief introduction of her. My speaker, Colonel Kayla Milla, Dr. Milla, as I know her, grew up in Port Jefferson, New York. She received her bachelor's degree in molecular biophysics and biochemistry from Yale University in 1998, and her medical degree from the State University of New York at Stony Brook in 2002. She completed her residency in obstetric and gynecology at Walter Reed Army Medical Center in 2006, and a fellowship in gynecologic oncology at Walter Reed National Capital Consortium in 2011. She's currently the Assistant Chief of the Department in OBGYN at Brooke Army Medical Center in San Antonio, Texas. She previously served as the Chief of that same department, OBGYN at Tripler Army Medical Center from 2020 to 2021, and the Division Chief of Gynecologic Oncology at Brooke Army Medical Center from 2015 to 2018. Dr. Milla served as a Deputy Consultant for Gynecologic Surgery and Obstetrics to the Office of the Surgeon General from 2018 to 2021. She has been a clinically active staff gynecologic oncologist at the Walter Reed Naval Medical Center in Bethesda, as well as the Brooke Army Medical Center we spoke about, and the Tripler Army Medical Center. She deployed as a Surgeon General on the 240th Forward Surgical Team Airborne in 2013 to Bagram Airfield, Afghanistan, and from there performed retrograde hospital missions at forward operating bases throughout RHC West. She's an associate professor of obstetric and gynecology at the Uniformed Services University of the Health Sciences, and a fellow of the American College of Obstetric and Gynecologists, ACOG, it's called ACOG, and it's a full member of the Society of Gynecologic Oncology, SGO, and has served in many capacities in both organizations, and is currently the Army Section Chair of the Armed Forces District of ACOG. Dr. Milla has also served on multiple national committees for ACOG and SGO from 2009 to the present, and has authored over 25 plus peer-reviewed manuscripts, book chapters, as well as reviews. Her research areas include endometrial cancer, ovarian cancer, and access and quality of cancer care within military health systems. Her military awards include a proficiency designator in OBGYN, Order of Military Medical Merit, and Meritorious Service Medal with 2 oak leaf clusters, among many more. Somehow through all of this, through her busy schedule, Dr. Milla was lucky enough to have been blessed with 2 beautiful children and a supportive husband whom we just met a moment ago, for which she gives thanks to daily for their support. Dr. Milla's interests include contemporary fiction, live performance, and long walks with complaining children. So let us welcome Dr. Milla to our program. Hi, Dr. Milla.
Hello. I'm so honored to be here.
Thank you. Thank you for accepting our invitation.
That's an excellent, extensive work done.
Congrats. And I actually took some out, believe it or not.
I didn't realize you were going to read the whole thing. I wasn't.
I took some out. But
that is extensive.
But some are very important, and I certainly do not want to leave that out, especially when you were deployed. I remember speaking to Betty from GOG, and I asked about you, and she said, Kayla's deployed. And I said, to where? And she goes, Afghanistan. It's like, oh my God. So we thank God that you came back safely.
Hey, if a Jewish girl from Long Island can do it, anyone can, right?
Before you start, is Afghanistan so scary as we see it from America?
Well, I was very fortunate to be within either Bagram Airfield or forward operating bases throughout the whole time.
Okay.
Because I was providing surgical care, and I followed the directions and I didn't venture outside. I think that in any sort of area or a place that you're unfamiliar with it, you need to approach it with respect. And I would say that unfortunately, given the uniform I was wearing, and who I was affiliated with, I had to be probably more careful than your average.
More careful. Okay. All right. Thank you very much.
So, but I really, my heart goes out to the people of Afghanistan right now, as many of the veterans on this podcast, I'm sure. I'm sorry, this whole this streaming lecture
program,
I'm sure are thinking about.
Yeah.
Okay.
Yeah.
All right. Really cool.
Well, if you're ready, we can get started. I know. Thank you again for taking us, because I know you just moved and you you have all kinds of things happening.
I'm so grateful for this opportunity and delivery of standard of care and innovative breast ovarian cancer treatment to all communities is very, very important to me. So I'm happy. This is a great opportunity for me to live by my principles. So thank you. But one thing I do want to mention before we get started is that the opinions that I share and the information I share is, yes, verifiable on many websites, but does not necessarily represent the official position of the United States Army, the Pentagon, SGO, ACOG, and all those things. So just be aware of that. I'm speaking as a private citizen. I'm not speaking as their representative at this time.
I think we appreciate that. We appreciate the fact that you come in as a private citizen to educate and give a public health information to our congregants and audience. Thank you very much.
Thank you.
And once again, thank you so much. I'm very honored.
Just a quick comment to the audience watch, and please feel free to start typing your questions in the chat box. And when it's time for question and answer, Dr. Eddie will project it for Dr. Milla to respond to them. Okay. So whenever you're ready, if you're projecting the slides, Dr. Eddie.
I'm ready to go.
Okay.
So I guess the first slide. If we could, once again, if you could click on the slideshow bit. Yeah, I think. Okay.
Eddie, did you click on it? Because it's not expanding. It needs to be bigger than what we currently have.
I believe there's a little ditzel. Sorry. I don't know if that's it or it's It should be that one.
It should be that one. Yeah. Do you want to go back to the first slide?
Yeah.
We can't see him now, so.
Sorry.
No. He's working it. Yeah, and just click on the first.
And if it doesn't, that's okay.
The initial slide.
More of my notes than I'd like, but I can do this. Okay, so this is my initial slide. It's ovarian. It's basically looking. That's a picture of an ovary, and the most important thing to understand. One of the things to understand about this slide is ovarian cancer can be from all parts of the ovary. For the most part, when we talk about ovarian cancer, we mean ovarian cancer at the surface of the ovary, but there are other cancers that are of the sort of substance of the ovary that's within the ovary, and there's actually ovarian cancer of unfertilized egg cells. The vast majority, however, is of the surface of the ovary. Next slide.
Dr. Eddie, are you there? I don't know. Let me send him a message. Something is definitely happening here.
Okay,
I'm here. I'm
Yeah,
here.
what's going on?
It's just that I don't know. I think compatibility with our system, but obviously I'm scrolling through. It's just that
yeah, are you able to hit up top or the bottom for slideshow, so it would just be a show versus
yeah, I've done
you've done that and it's
slideshow.
not
I did and it's not working out.
it's
So
not
I
working
think
out.
we might
Okay.
keep it as it is now.
Okay.
Well,
I wish
hopefully
we could
people
get it
can
bigger.
see.
Yeah, what we can do is also share if you give us the ability to do so on our platform so they can have it as well, because it's obviously an important topic. So, okay, Dr. Miller.
So, and this is basically right from the Ovarian Cancer World Alliance, but ovarian cancer, what everybody should know is, and this is everything I would tell my girlfriends or my girlfriend's moms, is that basically a pap smear does not detect ovarian cancer. So just because your pap smear is okay doesn't mean that you don't have ovarian cancer. For the most part, 75% of people, most people are diagnosed with ovarian cancer when they already have advanced stage, which means stage 3 and stage 4 disease, which we'll get into later. We really do believe that symptom awareness can lead to quicker diagnosis, and common symptoms are bloating, difficulty eating, feeling full quickly, pain in your belly, which can be either lower belly, which is your pelvis, or upper belly, which is your abdomen, and urinary symptoms. And what I mean is that usually women who have ovarian cancer, there's a lot of pressure on their bladders, so they go to the bathroom more frequently, or they really feel like they can't make it to the bathroom before they have to go. Next slide.
Let's see. That never happens. Okay.
Perfect. Okay, so this is a little hard to see, but it basically talks about all the various different kinds of ovarian cancer. The thing that people really most talk about when they're talking about ovarian cancer is the teal one. So if you look at the three teal circles, that's the vast majority of people who have ovarian cancer have one of those three, but there is a lot of diversity. And sometimes that means that, some people are going to have slightly different therapy if they have one of the more uncommon ones, and it's kind of hard to tell the difference. So just know that you don't always know all the details. Next slide. The problem is that when women are of reproductive age, which means that's basically from 20 to, well, honestly, 15 to 50, there's a lot of things that grow on your ovary normally that can cause symptoms but are not actually ovarian cancer. So there's tumors that are benign. There's things called endometriosis. Everybody who is ovulatory makes a cyst in their ovary every month to ovulate. And then there's other things that can look like ovarian cancer, like pelvic inflammatory disease, which is an infection that you can get of your entire reproductive tract. And those are all benign conditions. And then, but the things that really make it more likely to be cancer is if you're over 50, if there's really a lot of fluid in your abdomen associated with a weird cyst, and if you look on imaging, which is with ultrasound, and we're going to see that with the next slide, there's like these solid and cystic components. And then also there's evidence of spread outside the ovaries. So the thing that you don't have to worry about is the image on the left, and that's basically a big bag of fluid. That's called a cyst. Ovaries make them. Sometimes ovaries make huge cysts, but as long as it's simple and it doesn't have anything growing on the inside, you're fine. It's just a big bag of water, okay, or fluid. What you have to worry about is the images on the right. They have, like, what I usually kind of, like, the residents laugh at me because I do this sort of interpretive dance. They have these, like, little yucky kind of nodules in them that, like, look all scary and Halloween-like. That's usually bad. You can get that look with something like with benign conditions, but with these you have to have a much higher clinical index of suspicion. Next image. And when I say clinical suspicion, I mean you have to be more worried that it's cancer. That's doctor speak for I'm worried.
Something definitely going on with the system or the Wi-Fi. So just keep talking.
And that's okay.
Because you have your slides on hand, right?
Yeah, I have my slides on hand.
Okay.
So how do you take an image and differentiate between something that you see in an ultrasound, which could be cancer, could be not, and how do you figure out, well, it's cancer? And a huge part of that is the symptoms that the woman is having at the time where you see that image. So basically, most women have some sort of symptom. And once again, I'm going to repeat myself a lot in this talk. They have bloating, problems with eating. And when you look back at most people who have cancer, 69% of women who are diagnosed with cancer had were basically got an ultrasound because they're like, listen, I don't feel right. I have bloating. And the problem is all these symptoms are really gastrointestinal related. When you're talking to the woman, it doesn't sound like they're having a problem with they don't have a problem with their menstrual cycle. They're not bleeding. It's not really problems down there. It's problems all around. So people sort of think they have inflammatory bowel disease or they have irritable bowel syndrome, and they don't really necessarily work them up. So really it's the symptoms, you do the ultrasound, and those two things give you suspicion. You can do tumor markers to confirm, but symptoms with a really ugly looking ultrasound is enough for me to say, okay, we have to do some sort of analysis, especially if the woman is over 50. And usually, and the important thing also is to understand is that there's three different kinds of tumor. There's the ones that we worry about, which are malignant and they're invasive disease. And there's the ones that are benign. So, for example, you've had lectures and you may go on to have lectures about uterine fibroids. Those are benign tumors. Once you remove them, they can cause a lot of problems. Don't get me wrong, a lot of lifestyle problems. But you remove them, they're not going to come back for the most part, and they're not going to kill you as long as you don't have too much bleeding from them. With ovarian tumors, there are benign tumors like that. They may cause pain. They look not so great on ultrasound, but when you remove them, they're done. Okay. With borderline tumors, those are sort of tumors that are somewhat in between ovarian cancer and a benign tumor. They could be invasive. For the most part of them, 95% of them are curable with surgery, and you don't have to worry about it. Even ones that are invasive, most people survive just fine, and they go on to have other problems like heart attacks or strokes or other.
So would you consider borderline, would they be like stage 1, stage 2, or have you seen borderlines that are 3 and 4?
You can have borderlines that are stage 3, but they don't kill you. Okay. They're not the thing. They're not the bullet. Okay. I hate to put it that way, but
they're not the cell type.
That's a little army of me, but they're not the things. They're not the thing that's going to kill you.
Okay.
And then malignant cancer is something that if you don't treat, it will eventually spread and cause you to die of that disease for the most part. Basically, when you classify malignant tumors, you classify them by stage, which is how far they've spread. So, and grade, which is when you look at the tumor under a microscope, you look at it and the pathologist tells you how aggressive they look. And that can be for a whole lot of characteristics, which I don't want to belabor. I nerd out on these things, but you guys don't need to know necessarily all the details. But basically, you can see based on characteristics of what a tumor looks like under a microscope, how aggressive it's going to be. And that means how likely it is to come back or spread to other places. And so basically, low-grade tumors that are low stage, they have good outcomes for them. Sometimes you can just remove them with surgery and you're done, okay?
Yeah.
However, high-grade tumors that are advanced stage that have spread all over the body, they, for the most part, need chemotherapy. Even high-grade tumors that are aggressive, even if they're just confined to the ovary, they need chemotherapy too because they're much more likely to come back. So in sort of summary of what I've just said, epithelial ovarian cancer is not really the silent killer that people sort of make it out to be. For the most part, women have symptoms before they're diagnosed. They're not, and so what we have to do a better job of is listening to women, and if they have symptoms, evaluating them. They don't necessarily have to have surgery all the time, but the least if they have symptoms, you really need to start getting a pelvic ultrasound. And then if you see something on ultrasound, start trying to triage what that thing is to see whether or not they need surgery.
So primary physicians should really kind of take a look in terms of getting an ultrasound done versus sending them to a GI specialist thinking it's a gastrointestinal issue.
They can do both.
Okay.
You know, but that has to be part of the workup, especially in women who are over 50, and especially for women who have this weird combination of urinary and gastrointestinal symptoms like nausea, early fullness, bloating. So these, you know, when you see those things, you don't really necessarily think, oh, it's a problem with her female parts, but it could be.
Yeah.
So once again, you already nicely summarized that ovarian cancer is the most deadly GYN cancer in the United States. It's a little different around the world, where cervical cancer is more of a killer. And it's the 5th most common cause of death of women, behind lung, breast, colon, and pancreas. Your average woman, and that is everybody's risk of ovarian cancer, is 1 in 78. That has gone down over the past 10 years, so it's about 1.3%.
Okay.
And the average risk of a woman dying of ovarian cancer is about 1 in 108. So depending on the size of your high school, if you assume that there's like, your high school class has 200 people, 100 of them being women, one of the people in your high school class is going to probably die of ovarian cancer. Mm-hmm. And you can think of it that way. And that's sort of the scale of it. So that still impacts communities. Mm-hmm. Okay? So yeah, the risk is low to any one person, but the risk is high when you're thinking about social groups and organizations and a community. So I really wish we had this slide.
I know. I have a question about your last comment, though. Yeah. In terms of the risk, do you have the potential numbers for African Americans in terms of risk?
I was about to pull that up. So basically, you know, I'm not magic. Anybody can go to the SEER website. That's SEER. That's Sierra Echo Romeo, if you want to get all NATO alphabet on everybody. But so it's SEER.org, and you can look up ovarian cancers, and that can be searched by race. And basically, everybody's overall survival improving with ovarian cancer. And what you'll find is that basically it's more frequent in white women. However, the overall survival is better in white women than it is in women of color, and particularly Black women. If you just kind of, so basically, all comers, the African American, no matter what stage you are, when you present, African American women have about a 10% less overall survival than white women.
Yeah, that's because of late detection as well. Typically, it's advanced
for the most part, and then also I do think that the issue is that we're not doing enough screening of family members of women who have ovarian cancer for genetic predisposition, because there's an assumption that African American women don't have the same risk, which is not true, which I'll get into later. And also, we just want to make sure that all people get the same sort of innovative therapies. If you are diagnosed with ovarian cancer and a genetic predisposition is found, if you're given certain therapies, your survival is actually better. So, and we can see already that African American women are not being tested with the same frequency as white women are. Neither are Hispanic or Asian.
Yeah.
But, okay, so if we can go all the way down to slide number, let's try 20.
It's something on your screen.
Oh, actually, sorry, a little higher. I'm bad. Just let's try 15. A little bit more. Yes, that lady right there. The woman of blue race, right over there. Up. Okay, perfect. Okay, great. So speaking of that, this is the most recent stats from the American Cancer Society, which also looks at the SEER website just like that. So just go to the source if you want to. So there's 21,000 new cases this year, 13,000 deaths, which is slowly kind of reducing by 1,000 every year. Like I said, I didn't break it up in racial disparities. I'm going to get to the same slide further down the talk in the slide, but Basically 70 to 75% present with advanced disease, which is stage 3 or stage 4 disease. All people, the 5-year survival is about 47%. If you have stage 3 or stage 4, the 5-year survival is 29%. But if you're stage 1, the 5-year survival is 92 to 93%. Unfortunately, most people don't present stage 1. And then once again, if you wanted to break that up into African American women and white women are slightly higher at like more closer to 50%, and African American women are slightly lower, closer to 40%. And we'll get to that graphic again because I put it in my talk twice. Next slide. Risk factors. Okay, my little highlights, but basically the things that I wanted to emphasize is that the main thing that predisposes you to ovarian cancer more than the general population is the family history. So general population, like we talked about, it's a 1.3% risk of cancer. If you have a first degree relative with ovarian cancer, it goes up to 4.3%, your lifetime risk. And then things that also predispose you is if you have a BRCA1 mutation, your risk is 11 times the average person. And if you have a BRCA2, your risk is 5 times the average person. And that translates into a 40 to 50% lifetime risk for BRCA1 and a 15 to 20% risk for BRCA2. And then things that actually decrease your risk are down on the bottom, and we'll get into that again in another slide. So next slide. Oh, there we go. Okay. The main thing is that they just did a recent worldwide survey about people with ovarian cancer, about what they knew about ovarian cancer before they got the diagnosis. And the United States is not worse than everybody else. It's just globally, we're just sort of universally not teaching people about ovarian cancer. And honestly, we're not teaching first-line doctors or first-line primary care physicians, first-line nurse practitioners, PAs, whoever you see. We're not teaching them enough about this disease because it's not just the patient, it's also the first-line doctors that are less aware. So facts are that the median age of diagnosis is 63 years old. 15% of people who have it had identifiable family history or a genetic mutation that could have maybe been found out sooner. People who are increased risk have never had children. And the things that decrease your risk are being on birth control pills, having a tubal ligation, having been pregnant before age 25, and breastfeeding. And what those two other pie charts are on the other side is that most women, if surveyed, have no idea what increases your risk of ovarian cancer and what decreases your risk. So once again, it's not broken up by race. We're just all universally ignorant. So I guess we can be united in that. Okay, keep going. So I do a lot of repeating myself, but basically, having a child before age 25 may not be the right choice for you for economic reasons, but it definitely decreases your risk of ovarian cancer. But if you don't want to have kids, taking birth control pills for at least 6 years reduces your risk of 60%, and that effect is actually carried over to people who have genetic predispositions. So it basically is everybody, to the point that people who are say nuns have been offered ovarian cancer, have been offered birth control pills to decrease their risk of ovarian cancer if they have a family history. Tubal ligation, we're not exactly sure why. We can get into some theories later. And then once again, I mean, if you take out your ovaries and tubes early enough, you're not going to get ovarian cancer. Now, you're going to have a lot of side effects because you'll be essentially being castrated. But the question is, can we, and most people, if you're not carrying a mutation that puts you at risk for ovarian cancer, taking out your ovaries and tubes, doesn't just decrease your quality of life, it actually increases your risk of death from other chronic diseases. So we have to be careful. And then self-injectomy, just removing which is a fancy way of saying removing the tubes. And you can do that for birth control. We're hoping that will decrease risk, but honestly, we really don't know yet.
So quick question about birth control.
Yes.
Do they worry about blood clots at all?
Well, yes. You always have to worry about blood clots when you prescribe somebody birth control. However, there's a much higher risk of having blood clots if you're pregnant, 1. 2, in general, overall. Two, you do screen family history. The risk of blood clots go up if you have a family history of blood clots, if you are a smoker and you're over 35. But usually the risk of blood clots at age 25 is pretty low. And then it's important to have an estrogen component to decrease risk, because that actually kind of limits ovulation, but you can limit that with the birth control prescription that you give. So yes, it's a risk, but it's all about balancing the risks. And that's going to be slightly different with everybody. So the main thing is that we kind of overuse the word screening. I personally, although it's all over patient advocacy materials, I personally, if somebody's coming with me with symptoms and I get an ultrasound, I don't consider that screening. I consider that diagnosis. When these studies show that screening doesn't help, it's basically the women who are just off the street, have no symptoms, are feeling fine, which isn't really anybody, but are not exhibiting symptoms of ovarian cancer. And if you just do ultrasounds on them every year, it doesn't actually decrease your risk of dying from ovarian cancer. Ovarian cancer, the issue with ovarian cancer, and the reason why they call it a silent killer, is not so much that people don't have symptoms, is that we don't have a really good screening test for it.
Right.
A vaginal ultrasound is wonderful for diagnosing it if somebody already is having problems or having symptoms, but it's not going to necessarily tell, if you don't see something on vaginal ultrasound, it's not going to tell you that you won't get ovarian cancer later. The problem is it seems that what seems to happen is that women go from being completely fine on vaginal ultrasound and literally can have cancer all over their body 3 months later, and it's just the nature of the disease. So sometimes screening can give a false sense of security. While with mammogram, with pap smears, these are slow-growing cancers. They take a while to develop. It's a years-long process, so screening actually is effective. And what they did find is that there was no decrease in cancer mortality when everybody got an ultrasound and a CA-125, but the people who got an ultrasound and a CA-125 every year had more surgeries, and 15% of the people who had surgeries had severe complications. So everybody assumes surgery is the answer, but sometimes it's not there isn't really anything wrong, even though the ultrasound looks abnormal, and you can get complications from the surgery. So the real issue is that it's not about doing ultrasounds every year on somebody who doesn't have symptoms. It's about really listening to somebody who is symptomatic, and then when you see something on ultrasound, being aggressive about it, because the symptoms increase their risk. Okay. Next. Okay.
So the CA-125 obviously is a tumor marker that they use for ovarian cancer screening.
I was going to get into that. I'm sorry.
Okay.
CA-125 is a blood test, and I'm going to get into it a little bit later, but it's a blood test that you take when somebody has something that's not completely kosher looking on ultrasound, like those pictures of the little before. Sorry, it's interpretive dance. It does the job. But it's doing a CA-125 can actually help triage these patients. CA-125 is great for treatment because it's a way of telling whether treatment works. But it's not perfect, and it can be elevated for lots of reasons. Some of them common to women, like pregnancy, menstruation, ovulation. So it's not all it's cracked up to be, and that's why it's really important to do it with an ultrasound, and not just itself in a vacuum. And it's also helpful if the woman's symptomatic too. So once again, if you can detect a theme in my talk, basically, this is from another website, the Ovarian Cancer Alliance. 9 out of 10 women experience multiple symptoms prior to diagnosis of ovarian cancer, and this is women in early stage as well. But at the same time, 66% of those women had no knowledge of ovarian cancer if given a quiz before their diagnosis. Next screen. Okay, so once again, this is somebody with advanced ovarian cancer who's been preparing for surgery. And as you can see, this woman clearly had, denial is not just a river in Egypt. This woman clearly probably was having some symptoms. So basically what we find, and this is sort of the research getting into the nitty-gritty, is that a lot of women have this triad, which is a fancy way of they have these 3 symptoms, which is bloating, their abdominal size increases, they can't fit their pants on anymore, and they're a little embarrassed, but they don't want to say anything about it, and they have urinary symptoms as well. And that's present in women in cancer, but it's not present in women without cancer. And then once again, If you have anybody with unexplained abdominal swelling and pain, whether you can see it or not, because obesity could mask this, you get a pelvic ultrasound and you get the blood tests. Next page. So what we do is when somebody says, hey, I have symptoms, I think I kind of belabored that point, but this is what needs to happen, which is that you have them get an ultrasound. If the mass is suspicious, you then kind of drill down on the history and physical, because sometimes once you find something wrong, people remember more stuff. So you you redo the exam, you redo the history kind of in a more targeted fashion. You get those blood tests, and if it looks like on ultrasound, and if the CA-125 is really high, or another tumor marker is really high, you get a CAT scan of the body to rule out, to see if it's spread outside of the ovary. And then ideally, what we try and promote in SGO is that, and also ACOG, is referral to a gynecologic oncologist. I do believe if you go on the CDC website and other, sort of non-biased, non-gynecologic oncology groups, there is research that shows that women tend to do better if they're seen by a gynecologic oncologist.
Yeah. That's on the CDC website.
Yeah. And we can talk more about that too, because we don't necessarily make it easy for y'all. But but that's in an ideal world. So CA-125, to get into it more, it's a blood test. The problem is it's not perfect. Okay. So it can be normal in people who have ovarian cancer. So once again, if the person is over 50 and there's that and the ultrasound, I still advocate for surgery, because the only way we can prove it's not cancer is really by taking it out and having the pathologist take a look. It's definitely more accurate in women who have gone through menopause, which means they don't have periods anymore for at least a year. But the problem is it can be elevated for non-cancer reasons: appendicitis, ovulating, menstruation, endometriosis. But once again, if you see something that's concerning on ultrasound, if a woman has symptomatic, you should never use a normal CA-125 as an excuse not to operate. Mm-hmm. Okay, you have to. And once again, CEA is something that's important because it's a colon cancer test for the most part, but it can be elevated in ovarian cancer, and sometimes also colon cancer looks like ovarian cancer. If people have advanced stage colon cancer, it can spread to the ovaries. So it's a way of differentiating and making sure people get the right treatment. And then once again, it can be elevated for non-cancer reasons. Basically, if you're a smoker, I've had people who have CEAs of 15, actually that was 2 weeks ago. She had no cancer whatsoever. She was over 60, so we did do a bilateral salpingo-oophorectomy, but it turns out the reason why it was elevated, her colonoscopy was fine, we evaluated everything, and it turns out it was just that she was a heavy smoker. Okay. Yeah. So, but once again, you do your due diligence. You don't just say, oh, she's fine, she's a smoker. You rule everything else out, and then that was an exclusionary diagnosis. So once again, we talked about imaging, just to be aware if somebody's pregnant and you suspect ovarian cancer and you want to have more imaging above and beyond an ultrasound, it's not really ideal to do a CAT scan because that could affect the baby, give radiation to the baby. So we do an MRI. Next, and then it's time for an image. So just an internal anatomy, the purple structures are your ovaries. The things that look like sort of, once again, the interpretive dance like this, those are your fallopian tubes. And then the thing in the center is your uterus, and the bottom that's labeled 6, and the bottom that's labeled 6 is your vagina. So you can have cancer on any of these things, but what we're mainly talking about is cancer of the ovary. And this becomes important with the next slide. So you remember how I talked about stages earlier? This is where we break it down, okay? So this is actually true of any cancer. Stage 1 is always that you have disease confined to the original organ, or in this case, the ovary. Stage 2 is confined to the pelvis, so it's maybe spread from the ovary to a fallopian tube, or the uterus, or some bowel that's nearby. And then stage 3 is it's in the ovary, and then anywhere in the abdomen. So when I say abdomen, it goes up to your diaphragm or down to the bottom of your pelvis. And that's where if we find malignant cells there in the course of a surgery staging procedure, then you become stage 3. And they can be microscopic or they can be big. That makes you stage 3. Or if you have cancer in your nodes. Stage 4 is outside the abdomen. So some people have advanced stage ovarian cancer, stage 4, and it spreads to their lungs as fluid in their lungs. It can also spread to outside lymph nodes, and that makes them stage 4. And that makes them ultimately a lot less resectable. They need to be treated probably more with chemotherapy before they get surgery. Next slide. So to be honest, especially if you're advanced stage, most people need a combination of surgery and chemotherapy. For the most part, we're doing surgery, especially if you have stage 2 through 4, to make the chemotherapy more effective. When you have advanced stage ovarian cancer, you cannot cure it with surgery alone. You have to have the chemotherapy. As much as that is a step that most people in their right mind want to skip, you can't, because it's going to come back. It is possible to do, with early stage disease, to do fertility sparing. So if women are in their 20s and 30s and get ovarian cancer, which is not unheard of, especially with certain other rarer types, you can do a surgery where you preserve their uterus and one ovary and one fallopian tube, and then do other biopsies and to allow them to have children once they get put into remission. Next slide. So neoadjuvant chemotherapy is a fancy way of saying people getting chemotherapy before surgery. And this has become more and more standard of care for people who, when we look at their CAT scan, it looks like we can't have their entire tumor removed with surgery. The people who do best are people who, either if they get their surgery up front or they get their surgery later, have the entire tumor removed, at least all the tumor that you can see with the naked eye. There's some microscopic bits left, but that the chemotherapy gets. So whether you get the surgery up front or you get the surgery after some chemo shrinking it down, the max survival is if you get all the tumor out. So neoadjuvant chemotherapy is basically an effort to make sure that people get the best surgery possible when the time comes for them to have surgery. It's also very helpful for people who have diabetes, other chronic diseases, or the tumor is making them very sick. If they're smokers and have really, really bad lung disease. So they can, and I've definitely seen patients do this, optimize their health, and then while they're getting the chemotherapy, which I know is hard to believe, but it's possible, so that when it's time for the surgery, they don't have to have as long of a surgery, and they're actually in much better health.
So would they have chemo after surgery, then post-surgery? So have chemo prior to, then surgery, and then post-surgery chemo as well?
Yes, and that's the idea, is that you do you do about 3 cycles, 3 to 4. And then you do surgery, and then you have 2 to 3 cycles afterwards. And just think of that as like the final brushing it all out with a broom.
Yeah.
And the microscopic bits that we missed with surgery, we can get rid of with the chemo. The nice thing about neoadjuvant chemotherapy is that we used to not do it in the United States. It was much more of a European thing, but our surgical mortality rate has gone down. There are some people who have an aggressive enough surgery, or they're really, really sick. They die within 30 days of the surgery, because sometimes it can be very, very, very extensive. That has gone down for the most part with neoadjuvant chemotherapy. So if you die from your surgery, there's no way you can survive the cancer. So this is actually hopefully going to increase our overall survival. Next slide. So adjuvant therapy, that is a fancy way of saying chemotherapy after surgery. Okay. It can also refer to radiation therapy, which is less of a option with ovarian cancer, which I can get to in questions if you guys want to know more about that. So early stage, if it's, once again, low stage, stage 1, and it's low grade tumors, you may not need, or borderline, you may not need any chemotherapy at all. But even if it's a tiny little speck on an ovary and it's high grade, we recommend 3 to 6 cycles of chemotherapy, because we find that people recur if you don't give them that. And overall survival is 90% if you give those people chemotherapy, but it's only 60% if you don't. So it really does make a difference. And then stage 2 by then, and I'm showing kind of examples of stage 2 that in the picture, where you have tumor on the surface of the ovary, but it's also spread to the surface of the uterus and the fallopian tube, then you definitely get chemotherapy. And you definitely, once again, do 6 doses of chemotherapy, and then you follow that with targeted therapy if somebody has a genetic mutation or a tumor mutation. Next slide. So basically, for those of you that are facing chemotherapy, and for my patients who are facing chemotherapy, it can be an impossible mountain mentally. And I'm sure Valega has said the same thing, Ms. Roberts. I'm sorry.
That's okay.
It's both better and worse than expected. It's not as bad as you think, but it catches up with you. We're much better at treating nausea and vomiting than we used to be. In fact, we're much better at treating nausea and vomiting than when you and I worked together. The hair loss happens. There is some thought of, for the most part, I work for the military, and TRICARE covers wigs. Different insurance companies do different things. And there are some sort of efforts to keep people from losing hair they definitely cost a lot. I don't know how effective they are, to be honest.
Yeah.
Immunosuppression is something, basically, chemotherapy goes after rapidly dividing cells, which is great because cancer is a whole group of rapidly dividing cells. Unfortunately, your hair is a group of rapidly dividing cells. The skin that lines your GI tract, your intestine, that's a rapidly group of dividing cells. And then your bone marrow is also a rapidly group of dividing cells. And your bone marrow makes your red blood cells, your white blood cells that fight infection, and your platelets, which help make blood clots. So that is why when you give chemo to patients, and people who have cancer are immunosuppressed. We do think that people who have cancer are immunosuppressed baseline, but then the chemotherapy we give them doesn't really help. And then there is fatigue. Because you have a decrease in red blood cells, you also can be fatigued, but there also seems to be a fatigue above and beyond than just being anemic. But the good news about chemo is that for the most part, all the side effects are reversible. Your hair grows back. It may look different, but it does grow back. But the one thing that doesn't grow, that doesn't seem to subside, is the neuropathy. Now, this is a really busy slide, and I'm going to have to figure out how to make it better for like normal people. But basically, the standard of care is more and more, and this is where ovarian cancer gets expensive, is having some sort of, after you're done with classic chemotherapy, to have some sort of pill or even an infusion every 3 weeks called maintenance therapy. And that seems to give you more disease-free time. The problem is that during that disease-free time, you're taking a pill and you're coming every 3 weeks for treatment. So it's plus or minus, but for people who have BRCA mutations, it increases your overall survival for 18 months. And that's seeing another grandchild. That is seeing a child graduate. That is seeing a child get married. That is, and that is definitely worth it to people. So for people who have the 15% of people who have a BRCA mutation or something that's like a BRCA mutation, or even a mutation in the tumor that's like a BRCA mutation, they do really, really well. It's uncertain how good it is for everybody else.
So it's recommended that those who have a BRCA gene to do a maintenance therapy?
Absolutely.
Post-cirrhosis, okay.
That's randomized control. And once again, the people who do maintenance therapy, their overall survival increased by 8.
That's fine. Okay.
So that's why everybody has to get tested.
Yes.
Because it does make a difference.
So I'm looking at our time, and I'm wondering if
then let's go a little more quickly.
Yeah.
Okay.
And then see what questions. Dr. Eddie, if you have any questions, certainly stop posting them. I think I had tested that before. So the next slide, Dr. Eddie, I think you back away from the
next one.
Yeah, the next slide is coming. I think
Okay.
it's coming through. Just that I wanted to minimize and see if we have more questions or we have some questions.
No problem.
Okay.
Then once again, my next slide is there we go. Okay, next slide.
Yeah, that's a good one to segue in from our conversation.
Yeah. So next slide. I think I kind of belabored that point because
Okay.
it also makes a difference for your family, but it also makes a difference for you. So BRCA, I went into for the most part. If you have BRCA1, you tend to have ovarian cancer earlier than average. So you have it at age 50, and people who are BRCA1 carriers are a 20 to 40%. They have a 20 to 46% risk of getting ovarian cancer through their lifetime. The most famous example of somebody is, I guess, really Angelina Jolie's mom. She had both breast cancer and ovarian cancer, but it's the ovarian cancer that killed her. And that was back when we didn't have as much knowledge about BRCA patients. Next slide. Okay, just really quickly, there's some other mutations that are, make you, there's sometimes people who have a gene that predisposes them to colon and endometrial cancer. Also, that also predisposes them to ovarian cancer. A lot less of it's a 10% lifetime risk. It's called HNPCC, and the genes that you are mutated are highlighted in red. If you get genetic testing in your ovarian cancer patient, you will get all these tested. Next, and then these are other things that are tested. These mutations are less common. You have about a 5 to 10% lifetime risk of ovarian cancer, but they do also make you eligible for these special BRCA drugs that cause you to live longer. So once again, the main thing is that 70 to 80% of people with ovarian cancer, even if it's stage 4, respond to chemotherapy, and we can put them in remission. And that's a wonderful thing. That's not true of all cancers that are advanced stage. However, the vast majority of them recur regardless of what you do, regardless of how big the surgery is, 18 to 24 months later. Some of those people, and a lot of those people, we give them chemotherapy again, and they do fine. It's just usually the third and fourth time that they don't. And so these are all the other options we do to treat the recurrences. And the idea is that you can't really cure advanced stage ovarian cancer because you do eventually recur. But if you can turn it into a chronic disease, you definitely give people a lot more years than if they don't get any treatment at all. Next, so basically, really quickly, there's non-epithelial ovarian cancers. They're about 5% of malignant tumors. They're not really what you hear about in the media. They're either cancer of the inside of the ovary, or they're cancer of immature egg cells. Most of them are actually benign tumors. Next slide. Okay, so dermoid's most benign. And once again, if you do have a malignant germ cell tumor, it happens in people who are adolescents or in their early 20s. Most of them respond to chemotherapy and do just fine. You need to use the CA-125 doesn't work as well. You have to use different tumor markers. And then there's sex cord and stromal tumors. Those are tumors of the inside. So those are tumors of cells within the ovary that make estrogen, or cells in the ovary that just sort of keep it all together. And some of them are benign, some of them are not. And sometimes they present early because people have hormonal symptoms. Either they're making testosterone and they shouldn't, so they get hair or virilization, which is their voices get deep, or, and that's the sertoli lytic, or they're making estrogen, so their periods get completely thrown off, or they're stopped having periods and they start having periods again. So we're kind of, we get clued into them being present a lot sooner. Next slide. Okay, and then like I kind of alluded to, colon cancer can spread to the ovary. That's the most common. Breast can spread to the ovary. Gastric cancer can spread to the ovary, and melanoma can spread to the ovary. So about 10% of ovarian tumors are actually other cancers. Next slide. And then this is sort of, once again, not necessarily as important to the layperson, except in this one thing, is that we're thinking now and more that on a microscopic level, ovarian cancer starts at the fallopian tube and spreads to the ovary. And we found this in people who are getting prophylactic ovarian cancer surgery for people who are BRCA1 carriers and BRCA2 carriers who get their ovaries removed at age in their late 30s or early 40s. We're finding these little precursor lesions in their fallopian tube, not the ovary. They're completely asymptomatic. So mainly what we're actually advocating to all women is if you're getting a hysterectomy anyway, or if you're getting a tubal ligation anyway, just get your whole ovary removed, because that will decrease your cancer risk later. So to get into racial disparities, ovarian cancer affects all races. The yellow line is white women. The red line is African American women. So it is more common in white women. But if you notice, white women, the incidence is going down. If you look at the red line, it is kind of going down, but it's kind of even. So that is, I think, indicating the fact that women who are African American who have a family history, or women who are African American who have ovarian cancer, are not getting tested, and therefore their family members are not knowing that they should get tested too. Next slide. And once again, the green line is Caucasian women. The white line, sorry, the blue line is African Americans, and this is right from the SEER website. I didn't make this up, and this is recent. So what you're going to see is that the survival proportionally is much better for white people than Black people, and some of that also is that when Black women present with symptoms, they're not sent to the right place or they're dismissed. Yeah. Next slide. And so this is sort of a summary of what I've just said. There is a lot of data from this test called OVA1, which is supposedly more accurate than CA125, and they're doing a lot of, because they're saying that, oh, CA125 is more likely negative in Black women. And OVA1,
never heard that one before.
Yeah, well, they have lots of research, and there's really pretty graphs. I mean, if you want to Google it, Aspira. My main thing is that it's not about the CA125. It's not about the tumor marker. It's like listening to symptoms, seeing something on ultrasound that doesn't look right, and then removing it regardless of what the CA125 says. If the CA125 is negative, you're not fine. You still need to have the surgery. If the CA125 is positive, you might just have the surgery a little sooner. But when I say sooner, within the week rather than within a couple of weeks. And once again, that's the kind of thing that doesn't make a difference. The problem is people are having symptoms and then they're not being taken care of for 6 months. So when I say that they don't get care enough, and then I don't know, some of you all might be aware of this, but the talcum powder, I'm going to be really honest with you. The evidence against talcum powder is not airtight. Okay, there's no smoking gun, but there definitely seems to be an association. And asbestos definitely causes intra-abdominal cancer for other reasons. And in 2006, the World Health Organization said, hey, women shouldn't be using talcum powder. It could cause cancer. And in reaction, the large multinational company that made talcum powder said, oh, okay, and started promoting talcum powder in Southern African American churches and salons, radio ads. So whether or not you think talcum powder causes ovarian cancer, and once again, the association is strong but not airtight, they definitely did something shady. So this is something to be aware of, and it's something that happens again and again, that people take advantage for economic gain, take advantage of the fact that they assume one population group is a little bit more ignorant than another population group, and it's not right. So take home points. Persistent gastrointestinal symptoms in women who are over 50 should be evaluated, okay? All women with ovarian cancer should have to have genetic testing, and if that's not possible, and it may not be possible for a lot of reasons, their immediate relatives should be tested. The 25% of cancers that are caught at stage 1 can be cured. And once again, if you, God forbid, have ovarian cancer that's advanced stage, we can put you into remission. For the vast majority of people, we can put into remission. The problem is it does come back. But my job is very valuable because regardless, I get to give these people time to be with their family and to continue their life's work. And once again, getting into the symptoms again on the graphic. Next slide. So these are some good websites. I did link to a women of color focused website, which is the Resilient Sisterhood Project.
Okay.
And then the hereditary cancers. There's also a link to that too. And then the bottom link is just an article from NPR saying that, if you look at most of the data with just patient-centered data, most women, regardless of race, regardless of country, really don't know necessarily a lot about ovarian cancer unless it's a problem that directly affects them. Next slide. Okay, and then I'm done. Okay, sorry for going over.
Thank you. It's okay. Thank you. I know we had some challenges, and we apologize for it. That's what happens when things are being streamed live, right? It happens when you're not ready for it.
Also, sorry, that I could not share my slides myself. I'm figuring out my computer. So Dr. Eddie, thank you so much for covering down for me.
So do we have any questions, Dr. Eddie?
Yeah, we have some questions.
Okay. So first question: Do you see if the tumors are removed when you are, I'm
Well,
trying to say.
it depends. Okay, I'm gonna
Gotcha.
assume that it means that if you surgically remove the tumors, are you cancer-free forever? For the vast majority of ovarian cancer, no. You have to have chemotherapy too. But for the 5% that's and even some of the but the low grade, low stage tumors or the borderline tumors or benign tumors, then yes, you're cancer-free forever. And that's backed up by a lot of data. So once again, there are some people who have stage 1 cancer who they're done, even if they don't have chemotherapy. And then the people who aren't done, if they have chemotherapy, they have 90% survival, which means they're cancer-free forever, for the most part, at least 9 out of 10 of them.
What causes ovarian cancer?
Well, a lot of bad luck. But there does seem to be a genetic predisposition. But what happens is that it's natural for cells in your body, in order for your body to function correctly, need to be able to renew themselves. What causes cancer in general is that a cell that's renewing itself naturally all of a sudden loses the capacity to stop renewing itself, and it starts dividing uncontrollably. And this tends to happen in cells that rapidly turn over. So the surface of the ovary is, whenever you ovulate, the surface of the ovary is broken and releases all these inflammatory mediators. And for whatever reason, and that might actually affect the fallopian tube too, for whatever reason, that predisposes women to eventually develop this rogue cell that starts growing uncontrollably. And that's also true with colon cancer. That's why red meat is associated with colon cancer. It causes more damage to the interior of your GI tract. And that's why if you have lots of sunburns, you get skin cancer, because while your skin is repairing itself, there's this rogue cell that then all of a sudden doesn't know how to quit. I hope, but once again, there are people who have these genetic mutations that are passed on from mother to daughter, from father to daughter, where their there's natural mechanisms within the cell that cause it to turn off at the right time. They already have a problem with that, so they're more apt to develop cancer more frequently and at younger ages.
Okay. Do we have other questions, Dr. Teddy?
Yep.
Okay, just keep on rolling.
So the main thing is that tubal ligation is thought to decrease ovarian cancer. There's definitely a lot of linkage to that. And that's partially because it's believed that ovarian cancer, for whatever reason, starts on the tube and travels to the ovary. So people who have their tubes removed as part of a tubal ligation have less of a risk. And then also, for whatever reason, even just any sort of tubal ligation reduces blood supply to the area, and people have less of a risk. We're not entirely sure why that occurs. It might limit the ability of the cancer cells to spread from the tube to the ovary. But I don't think anybody knows right now. So it depends. If you get yourself into a clinical trial, historically your survival was 20%. Which translates into 12 to 24 months. However, I think we're going to have a newest, and I'm really quoting you data that's about, honestly, 10 years old. I think we're going to find that with people do better at stage 4 with the use of maintenance therapy, because those are the people who get the most bang from the buck of taking a therapy to keep you in remission. But still, honestly, most people with stage 4 cancer are not alive at 5 years. The clue cell, not necessarily, no. The rogue cell is just the initial cancer cell that turns into the cancer, and that's a cell that becomes immortal and starts dividing. So rogue, I use that as sort of a descriptor, but that's not a scientific term.
All right. I think that is all for the
That's all
questions.
that. Well, I have questions, but I'm going to just ask one of them.
Okay.
My question is, are all women at risk for any gynecological cancers?
Yes, because they have gynecologic organs.
Right. So every woman, there's a
Yes.
potential.
But I don't think that every woman should have their ovaries removed and fallopian tubes just because. All right. Once again, if every woman had her ovaries removed at age 40, putting aside the quality of life consequences, which would be atrocious, they would be more likely to die of heart disease, diabetes, things like that. So you all have to be aware of it. If you have a family history of ovarian cancer, you need to get tested. Continue seeing your doctor, continue having pap smears, and then if you have symptoms, please, please, please get evaluated. And if the person who you go to first won't evaluate you, go find someone else who will.
So talking about symptoms,
Yes.
can a woman diagnose or be able to say that I have ovarian cancer from home, like in the house, just look at herself and say that, hey, I have.
No, because honestly, the way you can be worried about it, you can have an increased suspicion for it. You have to go and get help and get an ultrasound or that sort of thing. We're not at the point where we can just sort of like pass an iPhone over our belly, although that would be awesome. And diagnose yourself with ovarian cancer. I mean, we can't even get the at-home COVID test, right? So, but if you're having those symptoms, seek help from a healthcare professional. And if you feel like they're not taking your concern seriously, find another one. Now, if you have an ultrasound and it's perfectly normal, then that's probably something that would reassure you. So it means you need further evaluation.
Yeah. And if you're postmenopausal and all of a sudden started bleeding again, it's not because your cycle has started. We used to always think that's endometrial cancer, but it could also be ovarian cancer as well. Yes. So that just needs to be checked out.
It just needs to be checked out.
Yeah. Well, thank you so much, Dr. Milla. Sorry, we had some difficulties.
Thank you for this opportunity, and I'm sorry for the technical difficulties.
No, it's on our part. So Dr. Adi and I would take that. But thank you so much. Thank you for taking the time. I know that you've been busy and you just got there, and we certainly appreciate you coming on. And I'm hoping that you'll be able to come on again once you get settled.
I would love to. And once again, it's the patients that make it all worth everything else, the long nights and the studying worth it. So I hope that none of you have to become one of my patients. But this was all about taking care of women and of all types and all people. So
thank you, Joe. Well, good luck. Good luck with the new position, and tell your husband thank you. For lending you to us, because you're an hour ahead of us. Actually, no, behind us. So behind us. So it's only 7:14 over there. So it's kind of dinner time. So we appreciate it.
But I will thank him anyway. Thank
you. Thank you. All right.
Good. I'm going to leave the talk.
Okay. All right. Bye-bye. Bye-bye. Wow. Okay. And then we're behind, and there's another church program that starts at 9:00. So Dr. Eddie and I will be getting off. But again, thank you so much for all those who contributed towards Janelle's surgery. And if you missed it in the beginning, Janelle is leaving for India tomorrow, that's Wednesday, to start her surgical process. They already have their tickets and visas and will be boarding tomorrow for her surgery. And as I mentioned, any monies that are left over that we're going to use that to purchase equipment. The church is going to use it to purchase equipment for Dr. Yao. As she explained, she has lack of equipment, and the equipment she has was broken. And so if God touches your heart to still help with this course, certainly feel free to forward any monies that you would like to contribute to the flyer that was posted on the church's platform. And we'll make sure it's on the platform again in case folks want to, there it is, in case folks want to contribute for that. But the monies will be used towards equipment now that Janelle's funds have been secured for her surgery. So Dr. Eddie and I will be back next month with special guests. We'll be discussing cardiovascular diseases, cancer genetics, as well as medical malpractice. And again, if you have not watched any of the segments we've had over the past now going on a year, they're all housed on the church's website. If you have any questions for us, feel free to send it to emcunyourhealth@gmail.com, and one of us will respond back to you. We are still in a pandemic, so stay safe, wear your mask, wash your hands, social distance. If you have not received your vaccines yet, please consider doing so. So have a wonderful evening. And I believe there's another program this evening that had to do with breast cancer. So make sure you tune into that. Have a wonderful evening. Thanks. Bye-bye.